Some go on the anterior abdominal wall. Yeah, there are the number of things we'll be talking about under the anterior abdominal wall. We'll talk about the function, the extent, layers of the anterior abdominal wall, and a special aspect called the rectus sheath, alongside neurovascular supply and the clinical significance. The wall of the abdomen is a continuous structure that surrounds the entire abdominal cavity. It is subdivided into an anterolateral wall and a posterolateral wall. Our major focus in this module is the anterolateral wall, and as a form of introduction, the anterolateral abdominal wall is said to be a musculoaponeurotic structure, so it's made up largely of muscles and aponeurosis alongside skin structures that tend to surround it. We'll talk about the layers and then we'll look at pictures in terms of the layers of the anterior abdominal wall and the boundaries in the next couple of slides. This is an image that shows the entire abdominal wall. If you pay attention, you know that this wall is continuous from front to back. It extends anteriorly to laterally and then ends up being um, posterior. So the part in which we are majorly focused on is the anterolateral aspects from this point all the way to this point. This is the anterolateral wall, and this is our main focus in this module today. What are the functions of the anterior abdominal wall? The anterolateral abdominal wall is said to be a protective layer for abdominal viscerals. The abdomen contains large amount of visceral structures, including organs like the liver, the stomach, the the jejunum, the ileum, and others alike. And these abdominal organs are very vulnerable to injury. As a result, they need to be protected heavily from the front and from the back, and particularly from the front. The major protective structure for the abdominal visceral is the anterior abdominal wall. Aside that, the anterior abdominal wall is also involved in assisting for forceful expiration. Expiration is usually done by the descent of the diaphragm normally, but when we need to forcefully expire, we make use of some extra muscles, and some of them would include the anterior abdominal wall muscles. It is also involved in decreased risk of hernia. The strength of the anterior abdominal wall prevents organs within the abdomen from herniating through the wall and protruding out, which is what we call herniation or hernia. So that the thickness of the strength tends to prevent or reduce the risk of hernia. And then finally, the anterior abdominal wall enables the trunk to bend forward or laterally. So the muscles of the anterior abdominal wall are also mobile muscles that can allow for forward or lateral motion of the trunk. Let's talk about the extent of the anterior abdominal wall. The anterior lateral abdominal wall extends from the thoracic cage above to the pelvis below. It is bounded superiorly by structures that tend to serve as extents for the abdomen, structures that we spoke about in the previous slide. For the superior boundary, we have the costal cartilages of from 7 to 10, and the xiphoid process of the sternum in the middle. And then for the inferior boundary, we have the inguinal ligament and the superior margin of the pelvic girdle. So these are the extents of the anterior abdominal wall. So this is an image showing us the extent of the anterior abdominal wall. You can see from superiorly, we have the xiphoid process in the middle, and then we have the costal margin, which includes the lower or inferior margin of the costal cartilages from 7 all the way down to 10. Then inferiorly, the boundaries of the anterior abdominal wall include the iliac crest, pubic symphysis in the middle, and then the inguinal ligament, as you can see laterally. Diving into the layers of the anterior abdominal wall from the outer layer to the inner layer, this includes the skin, then the superficial fascia. Superficial fascia is further divided into two sublayers. We have the campus fascia and the scarpus fascia, as you can see. The campus fascia is the fatty layer, the scarpus fascia, whereas it's the membranous layer. Then further down, we have the muscular structures of the anterior abdominal wall. Anteriorly, we have the rectus sheath and pyramidalis not shown in this image. Laterally, we have the external oblique muscle, internal oblique muscle, and transversus abdominis muscle. So these are the muscular aspect of the anterior abdominal wall. Behind the muscles, we have the transversalis fascia, and then behind this transversalis fascia, we have the extraperitoneal fascia. and finally the parietal peritoneum. And these are all the layers of the anterior abdominal wall from the right side to the left side all the way down. And let's talk in detail about each of the layers of the anterior abdominal wall, starting with the skin. Now, the skin of the anterior abdominal wall is a very thick and dense structure, and deservedly so because of the fact that it serves as one of the first line of protection for the viscera of the abdomen. The skin of the abdominal wall is innervated largely by the anterior rabbi of the lower six thoracic intercostal nerve and the iliohypogastric nerve. When we talk about the superficial fascia of the anterior abdominal wall, superficial fascia is made up largely of two sublayers, the campus fascia and then the scarpus fascia. The campus fascia is said to be a fatty layer, as you saw in the previous picture, and is the first and outer layer of the superficial fascia. The scarpus fascia, whereas, is a membranous structure and is the innermost structure or innermost layer of the superficial fascia. Then we have the deep investing fascia. Typically, we don't always talk about the deep investing fascia when talking about the layers of the anterior abdominal wall. The reason being, majority of most of the time, the deep investing fascia tends to be a part of the muscle. In fact, they say it can't really be separated from the muscle, and as a result, we don't really make mention to it. We just go straight to talking about the muscles of the anterior abdominal wall. Speaking about the muscles of the anterior abdominal wall, we have what we call the anterolateral abdominal muscles. Muscles that are found laterally and muscles that are found anteriorly. Muscles found anteriorly on the abdominal wall includes the rectus abdominis muscle and the pyramidalis muscle. They Both of these muscles are wrapped around by large sheet of aponeurosis called the rectus sheath. We'll talk about the rectus sheath later on in this model. But in terms of their origin and their termination, insertion, and innervation, they tend to differ. The rectus abdominis, for example, tends to extend or originate from the pubic crest and pubic symphysis and extends all the way vertically upward to insert at the xiphoid process and costal cartilages of the fifth to seventh rib. Whereas the innervations for the rectus abdominis muscle is largely done by the intercostal nerves from nerve 7 to nerve 11 and the subcostal nerve 12. And the action of the rectus abdominis muscle is flexion of the trunk and compression of the abdomen. So this is contrast to what we see for pyramidalis. First of all, pyramidalis muscle is an infrequent muscle. We don't see it in every single individual. Usually we say that the pyramidalis muscle is absent in about 20% of population. It is going to be extending from the pubic crest, ascending up towards the linea alba. It inserts at the linea alba, and it is innervated by the subcostal nerve. Pyramidalis muscle is involved in drawing the linea alba inferiorly, and that's its particular action in contrast to the rectus abdominis muscle. Some peculiarities you need to remember about the rectus abdominis muscle before we move on. The rectus abdominis muscle tends to have three about three transverse tendinous bands that tend to intersect it as it's ascending all the way up. And this band are what we call linear transversa. Aside that, the edges of the rectus abdominis muscle is usually called or termed the linea semilunaris. In case you hear the term linea semilunaris or linea transversa, remember they're talking about the rectus abdominis, just different portions of the rectus abdominis. The linea semilunaris talks about the lateral edge. The linea transversa talks about the three bands going to intersect the rectus abdominis as it is ascending all the way up. I'll show you pictures of how this looks like when we get to later aspects of the slide. For the lateral muscles of the abdomen, we have three lateral muscles. They include from outside to inside, we have the external oblique muscle, the internal oblique muscle, and the transversus abdominis muscle. Each of these muscles are also wrapped around by the rectus sheath, and they tend to be involved in the formation of the rectus sheath. The external oblique, for example, tends to run inferior medially. It tends to follow the same course as the external intercostal muscles. It runs from inferior medially. Remember that particular saying, ants in teeth and ants in pockets. In the case of ants in pockets, that's talking about the orientation of the external oblique muscle and external intercostal muscle. It originates from the lower eight ribs. It inserts at the linea alba, the pubic crest, the pubic tubercle, the anterior superior iliac spine, and the iliac crest. So it inserts at multiple places. The external oblique is innervated by the intercostal nerves from nerve 7 to nerve 11, and as well the subcostal nerve. and it is involved in flexion and laterally bending the trunk and compressing the abdomen. For the internal oblique muscle runs superior medially, so it follows the same orientation as the internal intercostal muscle. Remember, hands and teeth tends to signify the orientation of the internal oblique and internal intercostal. It extends from the thoracolumbar fascia, the anterior third of the iliac crest, and the lateral third of the inguinal ligament. This is the origin point of the internal oblique abdominis muscle. It inserts at the lower third or lower three or four ribs, linea alba, the pubic crest, and the pecten um, pubis. It is also innervated by the same nerves that supply the external oblique, and it tends to perform the same action as the external oblique abdominis muscle. For the transversus abdominis muscle, it runs transversely, as the name implies. It starts from the lower sixth rib, thoracolumbar fascia, the anterior three-fourths of the iliac crest, and the lateral one-third of the inguinal ligament. And it inserts at the linea alba, the pectinis pubis, and the pubic crest. It also has the same innervation and action as the other two muscles that are in front of it, which are the external oblique muscles and the internal oblique muscles. Now, moving on, aside the muscle, we all have some other layers that tend to complete the anterior abdominal wall from behind. So we have this layer includes the transversalis fascia, the external peritoneal fat and space, and the parietal peritoneum. Show you pictures about each of these layers look like in the next slides. So this will just wrap up what we talked about in terms of the layers of the anterior abdominal wall. You can see from out to in, we have skin, followed by the superficial fascia, particularly the campus fascia. That campus fascia is the fatty layer, as you can see in yellow. Behind the campus fascia, we have the membranous layer of superficial fascia called the scarpus fascia. Then from there, we have deep fascias that tend to be part of the muscles. In this case, we are seeing, we could see the lateral muscles of the abdomen. We could see the external oblique muscle first, followed by the internal oblique muscle, followed by the transversus abdominis muscle. And behind the transversus abdominis muscle, we have the transversalis fascia in yellow, it's rather in white, the extraperitoneal fat and space in yellow, and then finally the parietal peritoneum as the last layer of the abdomen. Just one more picture showing us each of the layers of the anterior abdominal wall. But particularly in this one is showing us the anterior muscles rather than the lateral muscles. So we have going again from outside to inside the skin, the campus fascia, the scarpus fascia, then the rectus abdominis muscle in this image. We can't see the pyramidalis muscle, however, because it is infrequent, it's not always seen in all cases, but we can see the rectus abdominis muscle in this image. Then we have the transversalis fascia, as you can see, the extraperitoneal fat and space, and then the parietal peritoneum. What you would pay attention to is the fact that the rectus abdominis muscle is wrapped around an extra sheet of aponeurosis, and that extra sheet of aponeurosis is called the rectus sheath, as you can see. So this is the rectus sheath. This is an outline of the rectus sheath wrapping around the rectus abdominis muscle. It has an abrupt ending somewhere around here. That abrupt ending is called the arcuate line. So this is where it ends anteriorly, and then we have it continue. It ends posteriorly rather, and then we have it continuing all the way up to the front. But at least this particular aspect of the rectus sheath I'm outlining is the area that is encapsulating the entire rectus abdominis muscle and pyramidalis muscle is present. So these are just images of the anterior abdominal wall muscles. You can see anteriorly we have the vector sheet, and you can see that tendinous band I'm talking about. You can see about three or four tendinous bands that tend to intersect through the rectus abdominis muscle as it's ascending. These bands are bands that tend to determine the popular saying of the popular image of a well muscular man that has a six pack. The six pack is formed by the tendinous bands intersecting through the rectus abdominis muscle, as you can see. Then at the sides, we have the lateral muscles. You can see the lateral muscles and their orientation, the external oblique running down inferiormedially, as you can see, and the pockets, the internal oblique running superior medially, you can see, and the teeth, and then the transversus abdominis running transversely, as you can see, all the way towards the linea alba, the pecten pubis, and the pubic crest. Let's talk about the rectus sheath. The rectus sheath is an aponeurotic sheath that is formed but as the continuation of three lateral muscles on both sides. It's an aponeurosis on both sides that is usually met at the point on the medial cervical plane called the linea alba. It tends to wrap around all the major muscles of the anterior abdominal wall. It is formed by the lateral muscles, where it wraps largely around the lateral muscles alongside wrapping around the rectus abdominis muscle and pyramidalis muscle. So this image is showing us the rectus sheath, as you can see on the side. The rectus sheath is this large white band of aponeurosis that is covering the anterior abdominal wall anteriorly. If you dissect through the rectus sheath, the set of structures you'll be meeting will be the rectus abdominis muscle. You can see it's the continuation of the lateral muscles. The lateral muscles here. You can see they continue as the aponeurosis, and then they eventually cover up the anterior muscles, the rectus muscle and the pyramidalis muscle. A very important aspect of the topic on the anterior abdominal wall is the formation of the rectus sheath. Rectus sheath is formed by the various muscles of lateral muscles of the abdomen, but this formation tends to differ whether we're talking about the anterior layer or the posterior layer. First of all, the rectus sheath has anterior and posterior layers, and the formation, whether anterior or posterior, tends to depend on what part or what level of the rectus sheath we're talking about. So to understand the formation, we tend to first of all divide the origin and composition of two layers um, of the rectus sheath at two major points. First of all, at the costal margin, at the level of the costal margin, and then at the level of the arcuate line. So let's talk about these two layer points. So this is what I'm talking about when we are talking about the formation of the rectus sheath um, within the abdomen. We talk about it from the perspective of 2 points. First of all, the first point is at the costal margin, that's point A. The second point is at the arcuate line, which is point B. Costal margin is the lowermost part or lowermost border of the costal cartilage, whereas the arcuate line is the point halfway between the umbilicus and the pubic symphysis. So at these 2 points, we talk about the formation of the rectus sheath because it tends to differ when we're talking about the anterior layer and the posterior layer of the rectus sheath. If we're talking about the costal margin, above the costal margin, the anterior layer of the rectus sheath is formed only by the external oblique aponeurosis, whereas the posterior layer of the rectus sheath is practically absent. We really have an anterior layer. The reason is because the posterior layer, instead of having a posterior layer, the posterior aspect of the rectus sheath is just replaced by the lower costal bones and cartilages. So by virtue of the costal margin, above the costal margin, we really have an anterior layer, and that is formed by the external oblique aponeurosis, whereas the posterior layer is lacking. So this is the image showing us the different points. You can see point A is above the costal margin. And what you notice is that the rectus sheath is formed only by the external oblique muscle, as you can see. And you can see how it just wraps around the rectus abdominis muscle anteriorly. Whereas the posterior part of the rectus sheath is replaced by cartilages and bones, as you see in this image. What about between the costal margin and the arcuate line? So that's below the costal margin, but above the arcuate line. The anterior layer of the rectus sheath between the costal margin and the arcuate line is formed partly by the external oblique aponeurosis or external oblique muscle, and then partly by the anterior layer of the internal oblique aponeurosis. So it's formed partly by external oblique, formed partly by internal oblique, practically. Whereas the posterior layer of the um, rectus sheath between the costal margin and the arcuate line is formed partly by the internal oblique aponeurosis and partly by the transversus abdominis aponeurosis. So what you just need to remember is that when you talk about the anterior layer, it's formed by external oblique and internal oblique. When I'm talking about the posterior layer, it's formed by internal oblique and transversus abdomen. So the internal oblique forms both the anterior layer and the posterior layer. This is a perfect image that shows us the formation of the rectus sheath between the costal margin and the arcuate line. What you notice is that anteriorly, this anterior layer of the rectus sheath is formed by a combination of the aponeurosis of the external oblique, this is one, and the aponeurosis of the internal oblique, this is two. You can see part of the internal oblique splits and then forms the anterior layer of the rectus sheath. Then the posterior layer of the rectus sheath, which is the part that's down below here, is formed by a combination of the um, aponeurosis of the internal oblique, which is the aspect labeled 2, and then the aponeurosis of the transversus abdominis, which is the area labeled 3, and that's what describes the formation of the rectus sheath at that point. Then finally, formation of the rectus sheath at the or below the arcuate line. The anterior layer of the rectus sheath below the arcuate line is formed by all three aponeurosis, so all three aponeurosis of the three muscles laterally, the external oblique, the internal oblique, and the transversus abdominis would give rise to the anterior layer of the rectus sheath below the arcuate line. Then the posterior layer of the rectus sheath below the arcuate line is practically absent. That layer is replaced by the transversalis fascia, rather than being formed by an actual aponeurosis. And this is the image that depicts for us the um, formation of the rectus sheath below the arcuate line. And what you notice is that all the aponeurosis of the lateral muscles, whether we're talking about the external oblique, the internal oblique, or the transversus abdominis muscle, they all have their aponeurosis joining together to form the anterior layer of the rectus sheath. Then the posterior layer of the rectus sheath is practically absent. It is just replaced by the transversalis fascia, as you can see in this image. What are the contents of the rectus sheath? As you'd have noticed in the previous images, as the rectus sheath is surrounding the rectus abdominis, we have some other minor structures found there. So the obvious structure that is found within the rectus sheath is the rectus abdominis. So aside that, in about 80% of the population, you can see the pyramidalis muscle. And then we have some vessels also contained within the rectus sheath. Vessels like the superior epigastric vessel has artery and veins, the inferior epigastric vessels, artery and veins, and then the terminal part of the lower five intercostal nerves. That's from nerve 7, nerve 8, nerve 9, nerve 10, nerve 11, and then the subcostal nerve, which is nerve 12. All these are contents of the rectus sheath that you need to pay attention to. All right, in this image, you can see some of the contents of the rectus sheath. If you expose the rectus sheath, you quickly observe the vessels found beneath the sheath. You have the superior epigastric vessel here, arteries and veins. We have the inferior epigastric vessels as well, arteries and veins present in this image. And then alongside that, you can see the rectus muscle itself, rectus abdominis muscle, pyramidalis muscle not shown in this image, but it's among the contents. And the nerves also not shown here, but they are among the contents of the rectus sheath. Let's talk about the neurovascular supply to the abdominal wall. The abdominal wall is supplied by a combination of superficial and deep arteries. Superficial arteries supplying the abdominal wall includes superficial epigastric artery, as we saw on the previous slide. This artery is found within the rectus sheath. Superficial external potential artery and then superficial circumflex artery. All are arteries supplying superficial aspect of the abdominal wall. Whereas the deep arteries of the abdominal wall is supplied by about four different sub-arteries. The upper part of the abdominal wall is supplied largely by the superior epigastric artery and the musculophrenic artery, whereas the lower half of the anterior abdominal wall is supplied by a combination of the inferior epigastric artery and the deep circumflex artery. Each of these arteries tend to harness the most with each one another to ensure great supply of blood to the anterior abdominal wall. What about the venous drainage? The venous drainage of the anterior abdominal wall is also by superficial and deep veins. Superficial veins include superficial epigastric vein, para-umbilical vein, and a thoracoepigastric vein. These veins tend to connect with different veins. For example, thoracoepigastric vein connects with the connection between the lateral thoracic vein and superficial epigastric vein. Particularly of note is the fact that it provides an alternative route for venous drainage when the portal vein and the vena cava are obstructed. Um, this is, by the way, we would practically learn about the epigastric vein and then the other structural veins when we go further the line during the module on the abdomen. The deep veins of the anterior abdominal wall includes the superior epigastric vein, the musculophrenic vein, the inferior epigastric vein, and the deep circumflex vein. These are just veins that tend to follow the arteries that we already mentioned. Now let's talk about the nerve supply to the anterior abdominal wall. The anterior abdominal wall is supplied largely by three major nerves. This includes the thoracolumbar nerves, which is a combination of the 7 to 11 intercostal nerves. These nerves also give sensory supply to the abdomen by way of the lateral cutaneous nerve of the abdomen and the anterior cutaneous nerve of the abdomen. Then we have the subcostal nerve, nerve 12, and the iliohypogastric nerve, L1. What you need to remember in terms of the nerve supply, especially in terms of sensory supply, is at dermatomal innervations of specific points on the abdomen. So for example, the xiphoid process as a point or landmark in the abdomen is supplied by the dermatomal innervation of T7. For the umbilicus, that is T10, and then for the area above the inguinal ligament, that's about L1. So each of these points, special points, have particular dermatomal innervations coming from each or one of two of these nerves that we already mentioned. So this is the picture showing us the innervations of the anterior abdominal wall. You see the lateral cutaneous nerves, which are branches of the thoracolumbar nerve. You can see the anterior cutaneous nerve as well, supplying the anterior aspect of the skin of the abdominal wall. The other nerves are not necessarily shown here, but these are just superficial nerves that are present here, like the lateral cutaneous branch of the iliohypogastric nerve. But what you pay attention to is that each of the nerves that I mentioned have cutaneous branches supplying the skin, as shown in this image. Like the intercostal nerve, the T7 to T10 and T11. This is a costal nerve T12, and then the iliohypogastric nerve, as shown in the image. So this is just a dermatomal innervation again. Remember that the umbilicus in particular tends to be innervated dermatomally by T10. The area just above the inguinal ligament is innervated by the L1, and the epigastric the xiphoid process or the epigastric fossa is largely innervated by T7. The vertex of the anterior abdominal wall is drained particularly by two separate lymph nodes. If it's the part of the abdomen above the umbilicus, the upper abdominal wall, that's the lymph around that area will be drained into the axillary lymph node. Whereas if it's below the umbilicus, which is the lower abdominal wall, lymph around that area is going to drain into the superficial inguinal lymph node. These are just the lymph nodes that tend to drain the abdomen. So any aspect of the abdomen above the umbilicus will be drained into the axillary lymph nodes. And then areas below the umbilicus will be drained into the inguinal lymph nodes as shown here. Let's talk quickly about clinical significance. There are two major clinical significance of the abdomen or the anterior abdominal wall, in particular, rectal sheath hematoma, which is likely uncommon, but whenever there's an injury to the anterior abdominal wall, we have blood pooling into the rectal sheath, and that will cause rectal sheath hematoma. Then finally, abdominal surgical incision. This is not really high yield, but it's important to know that when performing surgeries, we have different types of incisions that are made on the anterior abdominal wall. These include things like from the median line of midline incisions to paramedian incisions to McBurney's incisions to fenestrial incisions, which is done when doing a cesarean section, subcostal incisions. So this is an example of the image shows a vector sheath hematoma. This person most likely had an injury to one of the vessels within the rectal sheath, and as a result, there was a pool of blood within the rectal sheath. This created a large discoloration in the skin, as shown in this image. And these are the different incisions that could be made prior to surgery on the anterior abdominal wall. We have the contrast incision, we have the midline incision shown in two. We have the McBurney's incision, the Battle's incision, the Ian's incision, transverse paramedian incision, fenestrial incision, which is very popularly done in obs and gynae, Rutherford's Morrison incision, and others. These are not really high yield points to note. The incisions I think you should pay attention to will be the McBurney's incision, which is done for appendicitis, and then sorry for appendectomy, and then the financial incision, which is done for cesarean section. All other incisions are not so commonly spoken about in terms of your model as tutorial level students. And that concludes our module on the anterior abdominal wall.